musculoskeletal. Okay, so what are sprains? It's a strain. What's a strain? Stretching of which ones? Muscle and tendon. Sprains, stretching of what? Ligaments, yes. Rotator cuff, shoulder. So sometimes it's a tear. What are fractures? Bone. So any of these could be twisting. Let's see, trauma for any reason. What do we do for any of them? The first thing we do.
Rice.
Yes. So we do rice. What's R?
Well, rice is not the latest clinical practice.
Say it again.
I thought rice is in clinical practice.
Yeah.
I forgot the word.
What did they change? I can't remember.
Now it's mobilized. You move it and you put heat on it.
I have because I got my notes from Sanders, so and I guess I used it wasn't late enough. I guess I'll check back.
Seriously?
So let's pause on that one.
Well, last I heard I think they have taken out compression, but now they're saying there's like a whole separate, like a totally different protocol.
I'll look into it. All right. So what type of fractures are there?
Spiral.
Hair.
Compound.
Closed or simple. So yeah. Complex. Yes. Compression. What else?
Open.
Green stick. So the green stick one is one side of the bone is broken and the other is bent. Okay. Then there's an impacted. So you guys want to go over which ones they are really quick, what they mean? So we have the complete, we know what that one is, right? A complete break. Compression, a fracture bone is compressed by another bone. Depressed, the bone fragments are driven inward. The green stick, one side of the bone is broken, the other bent. And those are the main ones. Okay, so let's go to our next slide. So if we have a hip fracture, what are we going to tell our patients? Don't cross your legs. Okay, what are some interventions that they are going to do usually? Surgery, right? And we're going to have pain, so we're going to give them what? Pain medication, right? Maintain it in alignment, proper alignment, prevent external rotation. What else? They might have, if they do surgery, they might have what? Sticking out over there. Pins. So we're going to have to do the care for the pins, wires, screws, whichever. And our fear is what? Infection. Yep. Okay. We definitely give them medication for their pain. Okay. Total knee replacement. So all of these are very similar. Well, not exactly, but a few things are in common because surgery. So we're going to monitor the surgical site, look for drainage and infection. When do we start worrying about infection again? After day 3, okay? Because in the beginning, because of the surgery, it's going to be red, it's going to be swollen, it's going to be bleeding, right? It just won't have the discoloration or the pus or anything like that at all. What do we do about weight bearing? As tolerated. Yeah, as tolerated. So you usually just, as nurses, we wait to see what the PTOT says. So post-operatively, we're looking at the bleeding, we're looking at the weight bearing, we're looking at possible administering antibiotics if need be. Okay, we want to keep away from that though. Okay, how about the joint dislocation and subluxation? So subluxation is incomplete displacement of the joint. What will we see if it happens? Deformity, pain, tenderness, swelling. Loss of function, for sure. And the x-ray will give us exactly where, how, what, okay? How about herniation? What's our biggest problem with herniation? And where is it? Where would it usually be? in the disc, right? The spine, right? So we know if it's C, it causes a whole problem. If it's L, that's different. They're all different, right? Depending on where. So cervical disc herniation causes pain to where? The area, but where also? Because it's the spine. Below, right? So it could be shoulders, it could be arms, it could be scapular, right? It could cause spasms. What are our interventions for them? People with herniations. Bed rest. Bed rest, immobilization. Okay. Braces, depending on like if it'll help stabilize. Medication, what kind of medication are we taking? Pain meds, and what's another kind? Muscle spasms, right? Muscle spasms. Yes. Yep. Analgesics, sedations, anti-inflammatory agents. How about amputation? What's the main thing to remember about amputation? The first 24 hours, what do? Not cover. Elevate, right? So that all the blood doesn't rush and it bleed out. So first 24 hours, you elevate. Then after that, what do you do? After 24 hours, what do you do? Flat. See, mark bleeding or drainage on the dressing. If it occurs, you want to wrap it up. Never want to undo the first dressing ever. You want to monitor for complications. What would tell us they have complications? Pulses, right? Above. You want to see, is the blood, is there clotting? Is there an issue? Color, right? How bad is the pain? Is it excruciating? Is there something, the swelling is too much? Do they still have feeling in other areas? Okay. So what else? What's another problem with an amputation that we didn't mention? So it's the pH, phantom pain. Do we give medication for that? Yes, you do. It's still a pain. And the reason why is we still have that nerve. We can't remove the nerve, we just remove the limb. But whatever nerve that's connected to it still sends signals. Okay, so we give them the pain medicine. Okay, let's talk about reduction. Let's talk about fractures. Reduction factors. So restores the bone to promote alignment. There's closed reduction and there's open reduction. Okay, so we have fixation. Its internal fixation follows an open reduction. The internal fixation involves the application of screws, plates, pins, wires. Okay, let's see. External fixation, it's attaching the skeletal pins to the bone fragments. So we have risk for infection here, right? For traction, what does traction do? Traction is the exertion of the pulling force applied in two directions. So that's like the pulley, right? What don't we do with pulleys or traction? Do not what?
Adjust it.
Do not adjust it by what? By removing the weights, right? It's up to the doctor to decide how he wants to adjust what. We definitely want to check the ropes for frays. Okay, what else? Our interventions are the same with the others. Like you want to monitor the color, the motion, sensation, extremities, swelling, pulses, drainage, all of that. Let's see what else. What else? For skin traction, position the client with the head of the bed elevated 30 to 40 degrees. Buck's traction is a kind of what? Which kind of traction is it? Skeletal or skin? It's a skin traction, right? So it used to alleviate muscle spasms and immobilize lower limb by maintaining a straight pull on the limb. So some of the interventions for these skin tractions, again, same as the other, protect skin from breakdown, provide the care for the pins, clean it properly. Let's talk about casts. What should we know about casts? How many different kinds are there? How many? Which ones are they? Fiberglass, plaster, and there's an air cast, apparently. That one I didn't know about until reading over this. And they're used to what? Immobilize the bones or joints. Yes. So if you are using plaster cast or fiberglass, which one? Fiberglass. Which one dries faster? Fiberglass. And how could you dry a plaster cast if you need to? Or a fiberglass? Blow dry with what kind of temperature? Cool. Yes, so no heat. Okay, so allow a wet plaster cast 24 to 72 hours to dry. Okay, handle a wet plaster with palms. Okay, let's see. Okay, so how do we know that there are problems with a cast? Pain.
Increasing pain.
Definitely pain. Numbness. Pulses. Yes. Swelling. One more thing. Hot spots. Yeah, the warmth of different. If you touch it, it's like one place is cool, one place is hot. Yes. Okay. What does pedaling mean?
What does what mean?
Pedaling. If you're pedaling the cast, what does that mean? Like you put a piece of tape and you cover around their edges so that it doesn't rub and irritate. Okay. It helps with pedaling the cast or apply a moleskin to the edge to protect the client's skin. Maintain. Okay. What kind of things would you tell the patient about their cast? Don't get it wet. Don't put anything in it. Yes. Even if it itches. Okay. Yeah. What else? Monitor for infection. So what if it's extremely painful? What do? They gotta take it off. We gotta cut it off, right? Because that might symbolize what? Compartment syndrome. Yes. Okay, let's talk about some complications. Speaking about compartment syndrome, if we have a fat embolism, what break usually? Long bone. Yes. So if the fat embolism could go where? Anywhere. Right? It could go to the brain, could go to the lungs, but usually the lungs are like the ones that we think about a lot, right? So pulmonary embolism caused by the movement of foreign particles is the next step. So how do we tell that a person has pulmonary embolism? What would we see? Short of breath, restlessness, chest pain. Yes. So and it's sudden too. And anxiety, yes, that's part of the restlessness. What do we do for them? Oh, they could have coughs too. What do we do for them? We want to notify the doctor right away. Forget getting help. I mean, get help first. Notify the physician immediately if signs emboli are present. And then what's the next thing? So you call the doctor. What's the next thing you do? Oxygen. You want to give them oxygen. And you might start an IV to do anticoagulants, right? Because we know there's a clot. So now the compartment syndrome, we talked about, it's usually causes a lot of pain. So what happens that causes it?
It's like swelling inside the fascia
of the muscles. That's right. So it can affect arteries, veins, nerves, right? And so the damage needs to be rectified, or damage can be caused within 4 to 6 hours. So you can't wait, is what I'm trying to say. Let's see, increase the limb. So the tissue that is distal will be dusky, edematous, pain, pulseless. So those are the ways we can identify it. And if it's severe, the fascia, to relieve pressure, what do we need to do to restore the tissue? Cut it, yes. All right. Infection and osteomyelitis. What's the problem there? It could be a bone infection, and the infection could be anywhere else, right? So we don't want a fracture, an injury, a muscle, something to lead to infection or bone infection. So if we do have a bone infection or have an infection, how would we be able to tell? pain, fever, tachycardia. Yes. How about labs? Elevated leukocytes, white blood cells, right? And what do we do for it? Antibiotics, definitely. Pain medicine, right? Cool compress if we need to, if it helps, if it soothes. Definitely take a culture before anything to find out what kind, so we can treat it that way. Okay, musculoskeletal diseases. So I put these together. Let's run through them. So rheumatoid arthritis, what's that? Inflammation of what? Yes. Okay, so we have, let's see. Rheumatoid arthritis leads to destruction of connective tissue and synovial membrane within the joints. It weakens the joints. How do we identify it? We have elevated what? ESR, yes. And we do a biopsy. We can see that it's inflamed. There are rheumatoid factors. Okay. What are some medications we can give? We can. NSAIDs. And what's our biggest goal?
Slow it down.
Because we want to preserve function. Yes. And muscle strength. Osteoarthritis. Which one is this degenerative what? Joint disease? So it's deterioration of what? Articular cartilage. So it's the cartilage that's being affected. It causes bone buildup and loss of articular cartilage. So the greatest stress can be on your knees, your hip. Okay. And it's the same kind of identification and things that we're doing for the osteoarthritis or the rheumatoid arthritis. We want to keep function. How about osteoporosis? Yes. So the disease characterized by bone demineralization. So we have the loss of calcium and phosphorus. Calcium and phosphorus go together, right? So we know when calcium goes up, phosphorus goes down. They're that inverse connection. Bone restoration accelerates as bone formation slows. What else? Primary osteoporosis, we have most often occurs in postmenopausal women. And it occurs in men with low testosterone. How do we find it? How do we identify it? Pain. When they're stooping. What's that called? The hunch. Kyphosis. Yes.
I was gonna call it corphosis.
That was Kai. So what are some interventions? What are the interventions? Since it has to do with calcium, what do? Not just walk, but we definitely move, but we give them calcium, right? And how do we help them with absorb calcium? Vitamin D, yeah. Okay. We tell them to avoid alcohol and caffeine, prescribe bone strengthening, but you're definitely right with the walking because immobility causes it. So we definitely want to have them mobile so that the bones do not release their calcium. So definitely for that. Okay, next one, gout. Get out. Okay. So what is gout connected to? Uric acid, yes. So there, how do you identify it? Pain, swelling. Yes. Big time pain? Least big toe. Yes, yes. The old movies, like the old grandpa would have his foot on the toes wrapped up. Yeah. I put the cigar in his mouth. Okay. So what do we do? What do we do to help them? A low purine diet. Yes. Encourage what? Fluids to wash out all the purine that's in there. Encourage weight reduction. Avoid alcohol. What else? What kind of foods do we want to have them increase in? Green beans and broccoli. Yes. Okay. All right, let's see. What's the next one? Let's talk about crutches. What's important to know about crutches? How to use them, right? We got to be careful about what under here. Pressure, that's going to affect our axillary nerve. We don't want it to be destroyed. Yes, so definitely measure it so that you have the right one. Don't share. Know how to walk. Guys, I really do forget which leg goes first, but you need to know. So what I remember is put up the good leg first. That's what I want to remember. But go over that. Same thing with the canes and the walkers. I think the cane. See. It's a memory thing. You got to know it. You got to know it. So you got to remember how to walk with the canes, with the crutches. Let's see. Assist, like which side does it go on? Which leg do you put up first? So let's see. I have it written down here. For crutches, move the crutch to the affected side and grasp the arm. Flex the knee. Reverse the step to move from a seated, okay, up the stairs. So remember the up the stairs one. So going up the stairs, the client moves the unaffected leg up first. I knew that. Unaffected leg. I know. It's a memory thing. It's so annoying. So like every time you get it wrong, like just kind of repeat it to yourself. These are just like, they're so annoying. So crutches, good leg first. Unaffected leg first. And you move into the affected, move the affected leg and the crutches. So good leg first, then affected leg, then crutches. Good leg first.
I'm trying to picture that. It doesn't make sense.
Okay, so good leg first, right? Hold on, wait. Yeah, go back. Up the stairs. Up the stairs. The client moves the unaffected leg first. The client moves the affected leg and the crutches. So good leg and then both of them, crutch and leg, bad leg. Okay, so going down the stairs, let's see, going up and down the stairs. Up the stairs, the client moves the affected leg. You guys just read it through it. It's like so much. What time is it? We have 5 more minutes. Let's see, can we go fast? Can we get preoperative care? Just remember, what are we remembering? We care about person being well when they come out. We want to get them to their optimal health as much as we can. We're trying to decrease anxiety, so we don't want to teach them anything that they're not going to learn. So we want to get the right timing in order to teach them. We want to tell them what they're going to expect. So if they're going to need to cough, if they're going to need to take medication, all these things we want to teach them at the appropriate time. That's going to help them. Okay, so assessing the physiology. So you need to know how to do a head to toe kind of thing, but that's mostly practical. Latex allergies, other kind of allergies, fish, shellfish, that kind of thing. Yep. Antibiotics, if they're going to be on any. Some of the procedures do need antibiotics, so you need to know that kind of stuff, right? And consent from the doctor, that kind of thing. Whether the patient understands, you don't tell them if they don't understand something. You refer them to a doctor. That's important to remember. Okay. Anesthetics, we have general, we have local. Our interventions, when we are considering these things, we want to know, okay, does our lungs work properly? Can they breathe, right? Neurologically, can they feel? Circulatory, how are the pulses? Gastrointestinal, is there bowel sounds okay? Generatory, do they have 30 mLs or more? Equipment, what are they going to need in order to help? Like, is there going to be a drain? Is there going to be a chest tube? Is there, those kind of things. And then we want to assess for complications. So the vital signs will tell us how they're breathing, how's the pulse, how's the blood pressure. NPO, we need to know, okay, which ones they have to be NPO for. Any procedure they got to be NPO for, most of the time, right? So know which ones, and don't give them anything until gag comes back. Suction, oral cavities, monitor intake and output, pain intervention. Just remember the PCA, right? That's about it. And then we have our common postoperative complications. And we made it. All right. So I will see you next class.
I don't think we have those slides on.
Yeah, there is some.
Yeah, we don't.
So I'll re-upload it.
Thank you.
No problem.
I have a question.
Yes.
About the end of the quarter.
Uh-huh.
We're supposed to come on